Good morning. Hi, Galinda. Good morning. I just explained that only the presenter, Paul, and the two interpreters will have their cameras on. So if you could please turn your video off. Okay, thank you.
This is Roz. I'm looking at the Zoom now, and only those who are on camera are visible on live. So we're good to go. We have 3 minutes before we begin.
Hello, can you guys hear me okay?
Yes,
Okay.
we can hear you.
Great. I was having trouble connecting from my desktop, so I'm connecting from my laptop.
Thank you so much for joining us, Dr.
Sure.
Lee Buenconsejo-Lum.
Yes.
We'll start in about 1.5 minutes.
Yeah, and then is Dr. Sandra Chang in the waiting room as well? Because she's, rather expert in some of this as well. And so if at all possible, oh, look, I see she's on. So, I think she can be a good resource as well for some of the questions and answers. So she's on the Zoom, I see.
Hi, Lee. Yeah, I'm here.
Hi, great.
Hello, everyone. We'd like to go ahead and get started. I'd like to welcome Dr. Lee Buenconsejo-Lum. She's the co-chair of the Medical Advisory Group through the Department of Health and the group specifically related to the COVID vaccines. Welcome, Dr. Buenconsejo-Lum.
Hello, thank you.
The first question that we have related to the COVID viruses, could you please tell us what is the Delta variant?
Sure. And I'd like to also introduce Dr. Sandra Chang, who is on the call as well. Dr. Sandra Chang works here at the medical school with me, and she's actually a vaccinologist and has really been keeping up to date with all of the science. And so some of these questions I'd actually like to ask her to embellish. But the coronavirus has, like many viruses, has proteins on the surface, and that's the spike proteins that we've seen in pictures. And the variants are the viruses have evolved to change some of those proteins, and it can change how sticky the virus is an easy way to describe it. How well it sticks to the different cells in the nose and in the respiratory lining. And so depending on the mutation, then that's what makes some of those variants much more easily transmitted to others, and more likely to take hold and stay in the nose for a long time and reproduce. So the Delta variant is about 1,000 times more particles in the nose compared to the original virus because of this change in the protein.
Wow, we've also heard of another variant called the Mu variant. Could you explain that one as well?
Yeah, Dr. Chang, would you be willing to speak a little bit about the Mu variant?
Sure. So the mu variant is one of the new variants. It's not considered a variant of concern yet, which is, like the Delta variant, but it is emerging globally, and they have detected it in the United States. And so far, it hasn't been able to outcompete the Delta variant very effectively. But the concern there is this one, the mu variant, seems to be more capable of getting past the immune response induced by vaccination. So that's why they're very concerned about this variant.
You're saying that it's possible that the vaccines aren't being as effective against this variant. So what are the risks that go along with getting COVID versus getting the vaccine?
Sure. So and actually, I wonder if I could share a slide. I don't know if that's possible. I just put some slides together, graphic slides together to see, but I apologize, I'm having computer challenges. But at any rate, so what we know from the last year and a half of the COVID pandemic is that people who are who get it and who are not vaccinated, that means the fact that they haven't been vaccinated means that their body, has not been exposed to the virus. And we do know that disease is much more severe in people who have never been exposed to the virus before. So the people that are unvaccinated compared to the vaccinated group. And so the virus causes, it binds to the cells in the nose and the lungs, and it causes a lot of damage to the lungs in particular. And the body's immune response is like the army of the body, and it's going to fight off the infection. But this group of viruses calls a very strong immune response, such that we are seeing damage in other parts of the body besides just the lung. And so the lung disease is what we hear most about. That is what causes the lack of oxygen and a lot of difficulty breathing. And is really what causes the great majority of people with COVID to be hospitalized. It's that their body cannot exchange oxygen well with from the normal air. And so they need supplemental oxygen. And in the severe, so just needing supplemental oxygen is already considered severe disease. But many of them go on to develop very severe lung disease, where it's a pneumonia essentially, but it's caused by this virus. and by the body's immune system. And so what a pneumonia is that your lung fills with fluid and pus and cells, and it's not able to exchange air. If you think of a lung air cell like a balloon, and it's round like this, and normally it's thin, right? And you can kind of see the air through it. You shine it up to the light and you can see the air. If you were to fill that balloon with sand or gel or something like that, that's kind of the closest description of when you have a severe pneumonia caused by this disease. And so if you imagine something inside the balloon besides air, when you hold it up to the light, you cannot see it. Right? You can't see through it. And it's the same thing with oxygen. The oxygen goes through the lung cells, through a very, very thin membrane and into the blood vessels. But if something is blocking the flow of oxygen comes in from the outside and into the lungs, and it goes through the lung cells into the bloodstream. And that's how oxygen gets to the entire rest of the body. And so when you have a severe pneumonia caused by COVID, or pneumonia is caused by other things, of course, but in this case, the COVID causes pneumonia all over, and your body cannot get the oxygen through into the blood. And so that causes low blood oxygen and will contribute to a terrible shortness of breath, feeling like you're drowning or constantly gasping for air. It's what we call air hunger. And exactly, you're like this, you just have this panicked feeling. As your oxygen level gets lower, you develop lightheadedness and dizziness. Oxygen is also very important to keep the rest of the organs alive. And so we see people with COVID have heart attacks because you don't have enough oxygen to keep the heart pumping well. And there's going to be, and especially if you already had, say, pre-existing diabetes or high blood pressure, if you are already a smoker, or maybe grew up in a household where you were exposed to smoke for many, many years, all of those conditions already make you much more likely to have a heart attack or a stroke because the diabetes, high blood pressure, and smoking and high cholesterol cause the blood vessels to be narrow. So instead of a nice big blood vessel where the blood that's full of oxygen can go through to the brain or to the lungs, the heart, or the kidneys, if you already have kind of diseased blood vessels, and then now you don't have enough oxygen because you have this COVID pneumonia, then that's how we also see many, many people with heart attacks. Or sometimes the virus can directly attack the heart muscle itself, something called myocarditis or inflammation of the heart muscle. If the virus attacks the heart muscle itself, the heart becomes very weak. And instead of a nice, strong squeeze, then the heart gets really weak and it only squeezes like this. I don't know if you can see my hand. And then that causes heart failure. The lack of oxygen also causes a significant kidney failure. And so we see a lot of people with severe COVID disease needing hemodialysis because their kidneys can no longer process the waste and other things and normal kidney function. So COVID disease, generally starts primarily in the lung, but because it is such a severe disease and causes us in previously healthy individuals, it also causes a very strong immune response that can then damage other organs. And so when you hear of patients in the intensive care units, like we have been seeing on television, many times, in fact, almost all times, they're not just there for their lung. They are intubated. What intubated means is that they can no longer breathe and exchange enough oxygen by themselves. And so a plastic tube needs to be inserted in through the mouth and down through into the lungs. And then a machine is turned on to basically breathe for the patient. It'll force air in. It'll actually help to get the air out, because sometimes the lung gets so damaged that the normal breathing function doesn't work. And so the mechanical ventilator, or the ventilator, essentially breathes for the person because they no longer have enough strength to breathe on their own. But the patients in the intensive care units often have low blood pressures, very low blood pressures, because the heart and lung are damaged from the COVID. And so then they need a strong medicine pressure squeezing. If the blood pressure drops too low, they will get more of a heart attack. In other words, more of their heart cells will die off, and they will get strokes, because the brain will not have enough will not have enough blood flow that carries oxygen. And many times, as the organ in the heart starts to become significantly reduced or failing, then we see the kidney failing as well. And then you see the swelling and holding on to fluid, and a lot of medicines and other things cannot be cleared by the kidney, and so then a patient has to be connected to dialysis. And so patients in the intensive care unit will have a tube. If they're, again, very severe, they're often going to have the breathing machine with the tube. They will have large intravenous lines going in through the neck, because these medicines are very, very strong. And if we put them in through the regular IV you would get on your hand, the medicines they wouldn't work as well, and the medicines can cause damage to those veins. So the medicines have to go into the big veins, and for the best delivery, to help keep the patient alive and help keep the blood pressure. So I know that was a long answer, but that's essentially what severe COVID is. And so what we see is that people who are older, or people who have those underlying conditions, like cancer, or if they're on a medicine that they need to treat certain types of autoimmune disease, like rheumatoid arthritis, maybe they're on an injection medicine that helps to keep their immune system suppressed, or slightly weakens the immune system. Those guys, as well as poorly controlled people with diabetes, or people who have already pre-existing lung disease, pre-existing kidney disease, those are all of the underlying conditions that we hear about. And those people seem to get sicker. They get more sick than a younger person without any of those diseases. They tend to be hospitalized more. They also tend to end up in the intensive care more. They tend to die more. And all of this data was known with the original, SARS-CoV virus that emerged back in January 2020. But with the Delta variant, what we're seeing is that, some of these, in people with underlying conditions, the disease does seem to be a little bit different. And so just like before, all of those people, if they're unvaccinated, are at very high risk for being, in the hospital and dying. Now, one thing that is different with the Delta variant is, of course, how it's impacting younger people. So in the original big surges that we saw here in Hawaii, that was August and September of 2020. We, saw mostly older people, 65 and above, and, a fair amount of 50 to 64-year-olds in the hospital. Now, September 2020, we did not have the vaccine, right? So we saw a lot of folks in the hospital. We didn't see that many children in the hospital, and we didn't see that many teenagers or people in the 18 to 30-year-old category in the hospital. But now that Delta is here, and kind of from the US perspective, everything after July 2021 is when we consider the Delta period, the Delta variant period, because that's when the Delta became the predominant variant in most states. And so what we see is that even in younger people, in the 18 to 49-year-old range, unvaccinated younger people have a 23 times higher risk of being hospitalized compared to those in the same age range who are vaccinated. So in the 18 to 49-year-old, it's 23 times more hospitalizations. In the 50 to 64-year-old, it's 22 times more hospitalization. Interestingly, in the above 65 age range, they're still at 13 times higher the rate of hospitalization. But that number is because the great majority of people in this country who are over 65 and above are vaccinated. And so Delta is different because it makes a lot more, because of the changes in the protein, the increased stickiness. It stays around in the nose a lot longer. The load of virus, the amount of virus is about 1,000 times more when they tested it in the lab compared to the original virus. And because you have just so much virus, it is much more likely to cause a very severe disease, regardless of your age. There's questions though about children, right? And are the children also at increased risk of getting, hospitalization? And we certainly are across the country, and even here in Hawaii, we are seeing more and more children getting hospitalized. But thankfully, most of them are still, if they are healthy, most of them are not getting hospitalized yet. They are sick at home though, and that causes challenges for, they can infect the rest of the family. And they can affect the grandmas and the grandpas or the babysitters. The parents have to take time off from work because the child has to be isolated for 10 days. So even though the younger ages are not getting hospitalized as much as those over 18, they're still causing significant illness. And then of course they miss school, and there's all kinds of challenges when a child is, having to miss that much school. So anyway, so that's a long answer, but I think maybe help answer some other questions that your audience might have.
Yeah, I wanted to continue along this track of side effects in terms of long-term. What are we looking at there?
Okay, so good. So the long-term side effects of the disease of COVID, meaning anything that it can last more than a month. And so it can range from mild symptoms to very severe symptoms. The long COVID that we hear about, and the one that really causes people to not be able to work as effectively, are the effects on the brain. They get more, confused, or their concentration is not as good. And so it's actually difficult if they had a job that, required quite a lot of concentration and reading and analyzing things. It's actually hard to do that. And then the fatigue is also very common. People just not able to even to get close to what they were normally doing. And that fatigue can last for months. We see increased rates of depression or anxiety. And these are even in people who did not have depression or anxiety before they got sick with COVID. And with that, of course, it's hard to tell because you've also had, a very severe, in many cases, a life-threatening disease, and now you have a decreased function. And the coping with decreased function, can certainly contribute to anxiety and depression and other things. But the brain effects, so the cognitive, or the ability to think and concentrate and focus for long periods of time, the fatigue is very prominent. Some people continue to have muscle aches and weakness. The muscle weakness is seen more in people who had long intensive care unit stays. And that happens anyway. So even if people are in the intensive care unit for something other than COVID, we know that if they are basically not moving and they're very sick, even for 5 days, they're going to have some significant muscle weakness. And so the longer that someone is in the intensive care unit and not able to, walk around or use their muscles, then the much more likely is they're going to need rehabilitation. So physical therapy, sometimes even occupational therapy, helping the hands and dressing and feeding. And so we do see a lot of rehabilitation needs as well. From those patients. And then the patients who've been on the breathing machine for a long time, often will have trouble swallowing. The brain, the act of swallowing requires a lot of coordination between the brain and the nerves and the tongue, and closing off airways so that you don't inhale your food into your lungs. And so we do see that many people also will need speech therapy, speech language therapy, just to make sure that they can kind of retrain their bodies to safely swallow. So those are definitely the most common long-term side effects of COVID. People wonder about the vaccine, right? And vaccine side effects. And I think the original question was, what are the differences between COVID vaccine and getting the natural disease? And so we do know, from really over 1 billion doses given worldwide, but over 300 million doses given in the United States, that the COVID vaccine, the common side effects are local. They're related to getting the shot. And so, certainly the sore arm, maybe a little bit of lump here on the arm, or, occasionally in the lymph nodes on that same arm. And that's part of the normal immune response. Fever, sometimes I in particular, I had a pretty high fever, that started about 24 hours after I got my dose of the vaccine, but it was gone within the next day. And I did take one dose of a fever reducing medicine, because it was really high, and I was having a hard time, working at home with that high fever. But the great majority of the side effects from the vaccines only last 2 to 3 days, and in general, they're very mild. And yes, there are very, very rare cases when people can have a reaction from the vaccine, but the great majority, they're really very rare cases. So, whereas the side effects of getting the disease, even if you're not hospitalized, we do see people having their return of normal taste or normal smell. It takes a long time, and many times they also will remain fatigued for quite a long time, even if they were not sick enough to be hospitalized from COVID.
Just to add to what you've already said, for long COVID, what they're finding right now with the Delta variant especially is that even young people with very mild disease are later on developing long COVID. So with this Delta variant, I think there is a increasing concern of long-term effects of COVID infection, even in individuals who had mild disease and who were of young age.
Thank you. Yeah, the Delta variant is really not a good player.
Some people are wondering why the CDC and the government are still mandating masks for those who are vaccinated. Could you explain that?
Sure, that's a great question, and it really is because of the Delta variant. The original recommendations way back in May. That's not that long ago, but it seems like a long time ago. The original the studies and the modeling or kind of prediction. So looking at different rates and trying to predict how likely it is to give the virus to someone or transmit it. How likely is it for you to actually catch it and get sick and then to be hospitalized. So those are the models. So the initial recommendations back in May, for fully vaccinated people was that you didn't need to wear a mask indoors. But then, the Delta variant really started to take hold in June. And by June and July, the evidence was clear that even fully vaccinated people could get could catch the Delta variant. And the reason why they are still not as likely to catch it compared to an unvaccinated person. So the number 5 is important. If you a fully vaccinated person, yes, they can still get the Delta variant, but it is 5 times less than that of an unvaccinated person. So a fully vaccinated person can get it, but if you had a fully vaccinated person versus a non-vaccinated person in the same room, it is 5 times more likely that the unvaccinated person would get the Delta variant. Okay, so, but this person who's fully vaccinated could still get it. And that is why the mask is still recommended. And remember I said that the Delta variant sticks to the nose and it reproduces at a much higher amount and stays around a lot longer. And so that's why the breakthrough infections that you're seeing, because there's just so much virus that even with a great immune response from the vaccine, you're still able to get it. Now, the good news though, and there's lots of good evidence with this, is that fully vaccinated people, even if they get it, their immune system kicks in much more quickly. And really within about 3 to 5 days, they're not nearly as infectious as an unvaccinated person. So an unvaccinated person, once they get it, they can transmit the virus for 14 days, sometimes actually probably a little longer with the Delta because there's just so much virus. Whereas with the fully vaccinated person, if they catch Delta, yes, in those first 5-6 days, they certainly can give it to others. And that's why the quarantine, that's why the isolation is still the same, 10 days. But they have much less virus by like day 5 through 7 because the vaccine is working and their immune system remembers and is able to mount a very strong attack to that. But that's why the masking requirement is still recommended for everyone indoors, regardless of vaccination status.
We're receiving some questions from the community, and one question is, what are the ingredients in the vaccine?
Okay, Dr. Chang, do you want to take that one?
Yeah, I can take it. I saw that question in the chat as well, and I'm going to be putting in a website where you can get the exact ingredients. But basically, for the messenger RNA vaccine, it contains, of course, the nucleic acid or the messenger RNA. It also has several lipids that are used to make the lipid particle that carries the messenger RNA and kind of protects it from being degraded in the body and allows it to enter cells. So it has those lipids. And then it has some very common salts and other solutions that stabilize the messenger RNA. So it's very simple formulations, and they're pretty much compounds that you would see in cosmetics and in other food products, et cetera, very safe ingredients. I think for the messenger RNA vaccine, the one compound which some people are allergic to is called PEG, or polyethylene glycol. And individuals who have known allergies to this compound, as well as to another related compound called polysorbate, are advised, not to get the vaccine, or at least to discuss it with their physician before they get vaccinated so they can be monitored properly. So those are the ingredients for the messenger RNA vaccines. For the other vaccine, the Johnson & Johnson vaccine, again, many of the components are very simple salts and other types of compounds. This one does have a virus particle, but this virus particle cannot replicate or cannot reproduce itself. And so it just is used to carry the genetic information for the vaccine into the cells. And once it gets in, it just gets degraded. And so again, very simple components that really have not produced very strong reactivity in the majority of individuals who get vaccinated.
I want to touch on the mRNA. We had another question from the community, the concern about what's being said about the mRNA causing a physical change in the DNA and other negative effects, such as infertility and so forth. Is there any truth in that?
No.
You want me to take that
Yeah,
one?
maybe if you could elaborate, that would be wonderful. Thank you.
Yeah. So the messenger RNA vaccines, they do contain a compound called a nucleic acid, which is genetic information to produce the spike protein, which is what induces the immune response and what makes the vaccine effective. But this particular messenger RNA it gets into the cell, but it doesn't get into the part of the cell that contains your genetic information. And so there's no opportunity for that information to mix with your own genetic information and cause a change in your own cells. Okay, so for that reason, there is no risk of individuals' fertility being affected. There also have been studies in pregnant women at various stages of their pregnancy and who have gotten vaccinated at various stages of their pregnancy. And they have had normal deliveries. They have had normal outcomes for the neonate. And also for breastfeeding, there is no effect on the mother or the baby. So this genetic information is taken up by the cells, is used to induce your immune response so you can be protected, but it's eliminated very quickly from other parts of the body and has no long-term persistence or side effects.
Thank you. There's a lot of talk out there, and it's hard to figure out who we should believe and where we should get our advice. And how do we have conversations with folks who may have a different perspective about the safety and effectiveness of vaccines?
Sure, and that's definitely, I think, been very challenging for many of us in the health professions and in public health, right, who have been trying to keep the public safe, and so I would say that the Centers for Disease Control and Prevention has some very good information, and they have that is the source of information, but they have started to make some information available that is much easier to understand because much of the information, if you look at the science briefs, they're really meant for people like Dr. Chang and myself and others who who are very used to looking critically at different scientific studies and whatnot. But there is a website, and I'll also put it into the chat, where you can get some good, easier to understand information, whether it's about the vaccine or the vaccine ingredients. And thank you, Dr. Chang, who just put that information in the chat. There are information and even short videos about the vaccine safety in general, and then about vaccine safety in pregnant people or people who are wondering about fertility. And there are many of the data that comes out weekly in something called the Morbidity and Mortality Weekly Report, the MMWR. They have been now put into easier to understand infographics. So if people have questions about, really what is the difference between fully vaccinated and vaccinated, unvaccinated and fully vaccinated in terms of the likelihood of catching the virus or hospitalization or death, they have them in easier to understand numbers now. And so, the CDC, our Department of Health website, hawaiicovid19.com, the communications team has been working very, very hard to get the information to a level that is more understandable. They also have information in different languages, I think up to 15 or 18 different languages of those that are commonly spoken in Hawaii. There are some videos, and there are some that are in ASL, but mostly those are from the Centers for Disease Control. And then thank you, Dr. Chang also put a good educational site for the general public. So, and then the other thing is, we encourage everyone to talk with their, with their physician and their health provider. We know and we hear stories, that sometimes the folks are seeing information on social media from nurses or others that are helping to spread information that the virus isn't that bad, and other things. But again, we do not recommend that you use social media as your main source of information, and you should speak to your physician. But the Department of Health website has a lot of good information, and this getvaccineanswers.org also has a lot of good information.
Thank you. I also wanted to share with the audience that the CSC has videos related to COVID through YouTube, also related to the vaccine. So that's another resource that's available through the CSC's website. The next question, suppose you have a group of people who are all vaccinated. Is it okay for them to gather? Is it safe for them to gather?
That's a good question. And if you can verify, truly know that everyone is fully vaccinated, and if they have generally been around others who they can also verify have been fully vaccinated, which is a big if, and they don't have any symptoms at all, and they haven't traveled recently out of Hawaii, then, and again, those are a lot of ifs, then yes, it's safe, but again, there's a lot of ifs. And what we do know is that some of the breakthrough infections that occurred last month and the month before, and they were in the Hawaii Department of Health has a cluster report. And so in one of those, it was a large wedding, and most of the people were fully vaccinated, but they had out-of-town guests who had come from areas with very, very high levels of virus. And they did the, safe travels, testing and whatnot. But the timing was such that they became infectious and started to shed the virus, after they arrived in Hawaii. So in other words, they were, missed on the safe travels. Safe travels is good for the great majority, but there are, nothing is perfect. And so there are going to be cases like that where an infectious, person came in. And then as they did the investigation, it turns out that some of the fully vaccinated people who did get sick had also been in other large gatherings where there was a lot of unvaccinated people or where their vaccine status wasn't known. right? And so that's why we just have to use a lot of caution. And that is why, the Safe Access Oahu recommendation, right? If you're going to sit and eat at a restaurant or at, a wedding or some sort of venue, you have proof of full vaccination or a negative test. Again, that's not going to be 100%. Nothing is 100%. But it's definitely safer for fully vaccinated people to get together than unvaccinated, than a mix of unvaccinated. The problem is that the Delta variant, it's spreading so much in our community, it's really hard to know, exactly who's been exposed. And many times, just like with the original virus, you don't have any symptoms, but for about 2 days, but you actually you're capable of spreading the virus for a couple of days before you actually get your first symptom. And that's the challenge. And so that's why the universal masking is still recommended. And so if you're going to get together with a group of fully vaccinated friends, we still strongly recommend, because they don't live in your household, right? We still strongly recommend that you wear a mask and keep as much distance. And, if you're going to eat, it's definitely much safer to eat outdoors and to be physically spaced as much as possible. And that's why eating outdoors, is definitely preferred.
Thank you. The next question pertains to boosters. Could you briefly describe the boosters?
Sure. Dr. Chang, do you want to do that one, or I could? Up to you.
You can get started, and I'll just add something if you're missing. Yeah,
okay, sure, thanks. So, I want to make sure that we understand the difference between a third dose and a booster, because it certainly causes a lot of confusion, even in the healthcare world. So the first recommendation that was, authorized last month was for an additional dose or a third dose in immunocompromised individuals. So these are people with active cancer, with autoimmune conditions and taking certain medications, people who don't have spleens, either maybe they weren't born with one or they lost it in a bad car accident when they were younger. So people that have a baseline pretty reduced immune system, for those, the data, it was showing that they probably didn't mount a really good immune response to begin with. And so the third dose was authorized for them to get it so that, it could boost their antibody levels up higher. And so that's the third dose for immunocompromised individuals. The booster is really meant for those not immunocompromised, who already received their 2 doses, if it was the Pfizer or the Moderna, or the 1 dose of the Johnson & Johnson, and they were at least 2 weeks after that last dose, right? So that's what fully vaccinated is. So the booster is really meant for fully vaccinated people, and the evidence was discussed just this past week at the CDC, that in older individuals, 65 and older, it was the strongest evidence that they were getting more infections and more hospitalizations again. So again, the outcome of looking at reduced efficacy of the vaccine is looking either at hospitalizations, primarily looking at severe infections and hospitalizations. And when they have done tests on antibody levels, then it does show a slight decrease in 65 and aboves, and also a little bit of a decrease, in the time of Delta. So since July, a little bit of decrease in 50 and aboves as well. And so the booster, what it's designed to do is, in somebody who's already had the vaccine, your body makes these memory cells. And so it's not just the antibodies, which are short term. The long lasting immunity basically comes from the body and the immune system remembering, and there's something called memory cells. And then when you get exposed to the virus or to the vaccine, those memory cells and all of the rest of the cells really ramp up and have an even stronger memory and a stronger immune response. And so you're going to see higher antibody levels. You know, the caution and why I think some of the confusion, or not really confusion, but the data that you've seen or read about in the news with the Food and Drug Administration and the CDC is that almost all of these studies are just measuring antibody by itself. But we know that the true immunity to COVID disease is not only with that initial antibody measurement, because that is short term. And so it's the memory cells. And so that's why the recommendation from the committee, the advisory committee on immunization practice, really prioritized boosters, be given for those 65 and above and in long-term care facilities, because of their age already, they may not have made as great an immune response. And there was data both from antibody levels as well as real life, hospitalization data, meaning they got sick enough to be hospitalized, that those guys were at the highest risk, and therefore were the group that received would get the highest benefit of getting a booster. So that's in the 65 plus and those who live and work in long-term care facilities. So the best evidence for the boosters is in that older age range. But the boosters are meant to think of your immune system as primed, and it's learned about, and learned how to protect itself against the virus with the initial series of vaccine. But now you're going to give a booster, and so that learning, that memory, it's going to be more solidified. You're going to have a better long-term memory. For your body's going to have a better long-term memory of how to fight that disease.
And just to add to that, I know people have been asking me this question, so I'll just kind of mention the third dose versus the booster. So the third dose applies for both the Pfizer and Moderna mRNA vaccines. So if you've had either and you're immunocompromised, you can get your third dose. The booster is only for the Pfizer vaccine right now, because only Pfizer applied for the booster dose. Their data was reviewed by the FDA and the CDC, and they were eventually approved as described by Dr. Lee. But the other ones, Moderna and also Johnson & Johnson, are preparing their data for submission to the FDA and CDC. And probably in the next few months, or maybe even weeks, they will also be reviewed and determined whether boosters are going to be allowed for those vaccines. So a little bit of a delay for the Moderna and the Johnson & Johnson vaccine in terms of the booster dose.
Yes, thank you. And then related to that comes the questions, can I mix and match, because they feel they're at, a higher risk and would like to get a booster. And so we're certainly seeing those questions as well, meaning that I say I got the Moderna or the Johnson & Johnson, and it's been more than 6 months, and can I get the Pfizer now? The studies are still being done to determine the safety and the efficacy of mixing the vaccines, meaning having a different first dose and a different booster, or even a different first dose and a different second dose. And so at this time, that data hasn't yet been presented to the FDA or the CDC about the safety and the the efficacy. There are definitely studies done in other countries that have published some results that show that, they probably would be helpful. But we always want to, and the CDC and FDA really do want to make sure that there's as good as possible evidence to support, something on a widespread scale like this. And so, like Dr. Chang mentioned, folks who are 6 months past their last Moderna or their Johnson & Johnson, should just wait a little while longer. And I think within the next couple of months, we'll hopefully see those recommendations come out. But it will most likely be similar to the CDC, that the evidence is strongest for those 65 and above. And there's good evidence. It's not as strong, but it's good evidence for those with underlying medical conditions as well. And what the CDC in particular was using to balance the risk and benefit is really looking at how effective is a vaccine against hospitalization, because that's severe disease, and so it's really, again, the goal of actually every vaccine program. The goal is not to completely 100% protect against getting the whatever that disease is. The goal in again, almost all of the vaccines that we have had for years, the goal is really to prevent severe disease and severe disease, hospitalization, and death. And so when we recommend the annual flu shot, the flu shot is meant to prevent serious flu that can cause hospitalization or ending up on the breathing machine or death. The pneumonia shots that we recommend for people that are over 65 or people with diabetes is meant to prevent severe pneumonia that would end you up in the hospital or dying. And so we should really think about the COVID vaccines as the biggest goal is really to prevent the hospitalizations and the death. But we also know that it is also very effective in preventing infection. And like we talked about earlier, there, even in younger people, the infection can cause long COVID disease, and that can cause a lot of problems with jobs, caregiving, and life, and your ability to do your normal things again. People with long COVID have trouble doing that. So so I hope that helps.
And I did see in the chat box that someone asked, if they've had the second dose of the messenger RNA vaccine, can they just go ahead and get their third dose? And it's important that there is a time period between the second dose and the third dose. If you think about vaccines that already are present, like hepatitis or HPV vaccines, usually the third dose, they like to have it about 6 months after the initiation of the vaccination. So, and that's because it gives the memory cells a chance to develop in the body. So if you get the third dose too early, those memory cells won't be there. And so there won't be as good an effect of the booster dose. So that's why you have to wait 6 months before you get the third dose.
Another question from the community. What about ivermectin?
Oh, ivermectin.
Ivermectin.
Ivermectin. Yes. There is very clear, good scientific evidence that ivermectin is not effective to treat COVID, and it has very significant bad side effects, when given for COVID or given to humans. And so ivermectin really is not recommended at all. Yeah, and it's again, people hearing about a lot of things, sometimes people are like, well, it's this last ditch resort, and so let's try everything. But there's so much evidence to show that it is harmful right? And so we, in healthcare should not be giving things that we know are definitely going to cause harm. And ivermectin is one of those things that will definitely cause harm. And I'll put some information into the chat, or maybe sounds like we'll probably have a frequently asked question document or something that might develop, after this call, because there's just so many questions. But there's some good websites about why we should not use ivermectin, and I'll put that information in the chat.
We're getting close to the end of our time. So we want to look at the long term a little bit. What are you thinking in terms of long term for this? Are we talking about 1 year, 5 years? Is there any way to predict?
Yeah, I don't think we have a good way to predict, exactly how long. The CDC has been trying, and a lot of it really. A lot of it honestly really depends on what percent of the population is vaccinated. Because if you can get a really high amount of people vaccinated and or unfortunately who got infected with the virus, in particular with the Delta, and you build up that immunity, and where your body doesn't allow another strain of virus to take hold and to mutate, right? So it's really this race against the development of the variants. And so, and the way to protect against the variants are basically you have enough people unvaccinated and perhaps infected with the Delta or the Mu or other kinds of things, and it allows the virus to hang out long enough in humans to learn how to evade the immune system, right? And so that's why Dr. Chang mentioned why the Mu, variant is scary. So the faster that we can get a lot of people immune to the original, virus, then the less likely it is that these newer variants will really start to cause, widespread problems. And so, so the amount of the population vaccinated, the amount of the population who actually already had disease, those are factors. And then if we have, say, hopefully not, but say we do have enough of these other, variants that they do become concerning, then, then we're going to be in this longer, but I think that at least another year, of mask wearing. And, again, I think as this real world studies are being done, and there's studies ongoing all the time, and as more science, shows us what is safer, then we're going to see those recommendations change in terms of masking. But for now, we know that the mask is very important, to wear indoors or outdoors if you're in really large groups. So I don't know, maybe Dr. Chang has something else to add for that.
Well, I think you really summarized it well. I mean, we just need to follow the data, follow the evidence as far as what's happening, both at the national level, global level, in your own community, and continue to use all of the measures that are available to us to prevent getting infected and spreading the infection. And, patience is going to have to go along with that as well. But in time, we'll hopefully get to see a better outcome.
Thank you so very much. I really want to applaud both of you and thank you for your time in answering our questions. I want to recognize you again as Dr. Lee Buenconsejo-Lum, who is the co-chair of the Medical Advisory Group pertaining to the Department of Health, pertaining to COVID vaccines, and the primary investigator for the Pacific Disability Center. Also want to say thank you to Dr. Chang, who is the co-chair of the Medical Advisory Board, to DOH, and also a vaccinologist. We would also like to thank the Center on Disability, the Center on Disabilities and the CDC, Hawaii Deaf Blind Project for hosting this Q&A. And I've been told that Dr. Lee is willing to ask some more questions. We do have some additional questions. So we are planning to do a second session, hopefully sooner than later, and we can look for an announcement on that on the CSD website for a time when we can pick your brain a little bit more. Again, thank you so very much.
You're welcome.
Thank you, everybody. Take care. Bye-bye.
Bye-bye.